اوريدي في 5 في الويتنج روم، حضرتك بقى ممكن تخش عشان تخش قبلهم. تعمل انت بقى جوين وانا هعمل
اكتب جوين. هتعمل لي انفيتيشن ولا
لحظه واحده لحظه واحده. حضرتك موجود عندي في
انا منتظر.
موجود عندي في موجود عندي في
ما احنا من اول المره اللي فاتت. thank you very much. تمام.
نجيبك بقى انا من تحت هنا اهو. دكتور احمد ناصف ادمت.
الكمبيوتر هو انا المفروض متهيألي اخلي
كمبيوتر اوديو. يوز كمبيوتر اوديو. جوين والكمبيوتر اوديو.
اوكي انا شلت انا سامعك على فكره في الكمبيوتر.
خلاص بقى احنا كده دخلنا جوه بقى زي ما
طيب نعمل شير سكرين بعد كده.
ممكن بقى تعمل شير سكرين. مش مشكله خالص. ثواني اما اعمل لك كو هوست الاول.
اوكي.
اعمل لك كو هوست. more co host. يس. انت دلوقتي كو هوست تمام؟
تمام. اوكي. شيرنج سكرين بقى من فين؟
المربع الاخضر اللي تحت ده.
شايفه. مربع اخضر تحت.
في النص على طول من ده. او فوق، لو انت عامل فول سكرين يبقى فوق.
لا انا مش عامل بس اعمل فول سكرين.
في عندك زي الدوريه فيها سهم باصص كده لفوق مكتوب عليه، تحتيها مكتوب عليها شير سكرين.
شفتها تحت. شير سكرين. صح. بعدين نعمل بقى مش لاقي حته هجيبها ايه؟ ما ريسيفد فايلز ولا دي؟
انت فاتح الباوربوينت ولا لا؟
لا.
طيب افتح الباوربوينت الاول. وانت انت على الكمبيوتر ولا على تليفون؟
لا على الكمبيوتر.
طيب افتح الباوربوينت الاول وبعدين اعمل شير سكرين.
فتحت الباوربوينت. مش عارف انا رحت فين.
And so let's begin with the A. So my aim here is to me it's a simplification, but I'm trying to tie the anatomy with the visual field in all aspects and how to read it and how it was done. And to me, this, if you know the basic knowledge, then the whole aspects of whatever you're studying becomes just common sense. In the end, we're going, if we have time, if you have still some energy left, we can do a chart reading, how to look at a visual field chart. So let's start. Now the eye, for a long time, since the ancient Egyptians, has been the subject of great respect. It has its mystique and mythology that surrounds it. But in the end, the eye's only function, other than looking beautiful, is vision. We all know in our clinics that first thing we do is measure the best corrected vision of any patient. Now, this vision is actually not only the eye, but the whole neurological visual system. But if we focus on, so let's say that somebody sees visual acuity of 6.6. Okay, so this shows that he has good macular function and good optic nerve, and all the whole pathway system is working fine. But let's take a look. So let's say if somebody's looking at this and his vision is 6.6, And it begins to constrict, something's going wrong, but in the end, he's still seeing 6/6. But what has he lost here? Now, this is a typical case of concentric visual field constriction in a glaucoma case. His vision is still 6/6, but his field has been compromised. So let's talk about the visual field for a second. Now, as you see from this drawing, the visual field is actually quite wide, especially in the temporal zones. You can see that it can reach 95. Actually, there are some textbooks that have written it reaches up to 109 degrees. It's quite wide. There's an overlappment in the middle 60 degrees. This is where the right and left visual fields overlap. So this is important. Why? Because if I want to measure the visual field of a person, I have to occlude one eye. That simply makes sense. So this just shows the measures. You'll note that the extent of the field actually depends on the bone structure of the face. So that's why it can be variable. So it's 60 degrees upwards and nasally. So nasally, it's the visual field is compromised by the nose. And then temporally, as we saw, it can be 100, 109, less than 100, and so forth. And this is what it would look like if we chart it. It looks very close to how the orbit looks. Now, just keep this in mind as we go through an important point. It's a simple one, but an important one. When you look at a subject, so there's the upper half of the field. If the middle part is the fovea, this is what we call fixation. Then above the fovea, above the fixation, is the upper field, which is seen by which part of the retina? The upper or the lower? The lower retina sees the upper field. The fovea sees the center. The lower retina sees the upper field, while the lower field is seen by the upper retina. And vice versa, the right or the temporal field is seen by the nasal retina, and the nasal field is seen by the temporal retina, which will bring us here to the visual pathway. This part of anatomy has to be well known to understand anything regarding the visual field. If we don't understand this, the visual field will be tough, very difficult to comprehend. But if you know this, it simply makes sense. It will become very easy to diagnose and to reach conclusions and to pinpoint and locate where the pathology might be. So if we take a look here, we'll find that the visual field, we can see the same shapes that we saw in the last slide. Now for the right eye, you can see half of it is in white, the nasal half is grayish. And the left side, the temporal half is grayish, the nasal side is white. So if we say that the right field, so the temporal on the right side, nasal on the left eye, is the right field is white, the left half, which is the temporal for the left and the nasal for the right, is in gray. Now, let's take an example of the right temporal field, which is in white. So the right temporal field is seen by the nasal retina. So let's point this out. And the pointers, here they are. Okay. So this temporal field will be seen here, will be seen by the nasal retina. The nasal fibers will cross in the chiasma to reach the left optic tract. Here's the left optic tract and continue to the lateral geniculate body, which is part of the thalamus. Now, with it is the nasal field of the left eye, which is seen by the temporal fibers of the retina, temporal retina, and it passes through the optic nerve to the chiasma and uncrossed to the same side. So on this left tract, optic tract, the visual fields of the right half are carried here and here. And vice versa on the right side. So the right optic tract will be seeing the grayish part of the halves of the visual field. This one, the nasal field of the right eye, which will be carried by the temporal fibers here, pass and cross, and vice versa, the temporal field here, carried by the nasal fibers that will be crossed and come with it here on this part to the lateral geniculate body. So what we are saying is that at the left, starting from the left optic tract, the visual field is carried according to right and left halves. The left optic tract will represent the right side of the field. And vice versa, the right tract will represent the left side of the field. This will go on through the lateral geniculate body, following with the optic radiation down to the visual cortex. I hope this is clear. So let's repeat it quickly. And let's say again, we'll start from as we started at the beginning, the right field, the white right field here is carried through, seen by the nasal fiber, nasal retina, carried through the optic nerve, crosses in the chiasma to reach the left optic tract. It crosses. And with it, the white part, the nasal field here, will come to the temporal retina, which passes uncrossed in the optic tract, which will carry now. The left optic tract will be seeing the right half of the field and continue all through to the visual cortex. Again, but here there's a little detail more. So we can see here, for instance, that this lower red quadrant of the left eye sees the upper left quadrant of the left eye, and this lower fibers will pass to the retinal geniculate body, but they will continue in the optic radiation. Suddenly we have the optic radiation splitting, one part above, one part below, and we'll see that. This part below actually passes at the temporal lobe. So if this is affected, then this quadrant is affected, along with its neighbor, this one, which also passes here, seen by the temporal lower quadrant, also passes to the lateral geniculate body along with it. So you'll find these two quadrants missing if the lower half of the optic radiation is affected. Now, the whole point of this, the difference here is that the optic radiation shows that it is splitting into two halves. The upper half representing the upper fibers of the retina, which means what? The upper half shows which type of field, which part of the field? The lower field. While the lower half will show the upper field, will represent the upper field. But each is a quadrant on its own. Let's take a look at the next one. So this is a schematic presentation. The optic nerve here, the optic chiasma you can't see because this is a side view, and then the optic tract down to the lateral geniculate body. And then the parietal fibers, the optic radiation passes here in the parietal lobe, while this temporal, this loop, which is called Mayer's loop, is pushed down by the inferior horn, down here as we see it, see? It passes down with the inferior horn, which this occurs embryologically, separating the lower half, the lower fibers, which represent the upper field, represent the lower fibers, and down to the temporal lobe in front of the inferior horn. So a lesion here at the temporal lobe will affect only the upper field, and lesions in the parietal lobe here will affect the lower field. Now, I hope up to now things are clear. Let's take another look. Maybe they will clarify for those who find it still a little obscure. Now, if I take this is the same presentation of the visual pathway, and if we cut the optic nerve here, we'll have simply the right eye visual field is lost. But if you come to the chiasma, now here we said what crosses the nasal fibers cross. Now the nasal fibers represent the temporal fields. So we'll have a bitemporal, hemi, half, anopia, blindness, due to the mid-chiasmal lesion here. So what the nasal fibers here are affected, the nasal fibers here are affected. These see the temporal, and this sees the temporal, so it causes bitemporal hemianopia. But not all chiasmal lesions have to show a bilateral visual field effect. So suppose it just comes from the side of the chiasma, what will it show? It will affect the temporal fibers here that come here, uncrossed. And this will cause what? Temporal sees the nasal field, so it will cause right nasal hemianopia. So not all chiasmal lesions have to be bi. They can be monosided. Now, if we go back here, we remember that starting post-chiasmatic, this is all post-chiasmatic. So it will always take one part of the field. So if it's at the right side represents the left field. So here it will cause a hemianopia of the opposite side. So this is the right optic tract. So it will cause a left homonymous hemianopia, simply. So what about if we go to the optic radiation that we just talked about? Now, if we damage the upper parietal fibers, they will affect the lower quadrants of each eye. So this is called pie on the floor or quadrantanopia. Also, if we take number 6 here, it will affect, what will it do? Quite the opposite. It takes the lower fibers, which represent the upper quadrants. So it's a left, so homonymous superior quadrantanopia. So what about if we go backwards to the visual cortex where all the fibers are very condensed together and we can get a left homonymous hemianopia completely. But we just remember that number 4, which was at the optic tract, gives the same picture. So we need to remember that if we have a left homonymous hemianopia or a right homonymous hemianopia, the lesion may either be in the optic tract or may be in the visual cortex. It really depends on how close the fibers are together. Now, let's talk a little about chiasmatic lesions. So the most famous, just a few points to keep in mind. A chiasmatic lesion is usually bitemporal. But that is also where you can only get a binasal, which is quite rare. But if you get a binasal hemianopia, ask for an MRI on the cellular area, because it can also cause a binasal hemianopia. All lesions post-chiasmatic are homonymous hemianopias, like this. So this, it takes the whole total area. So it's a total homonymous hemianopia. If it's total, we don't talk about congruity. What does congruity mean? It means that they are similar to each other. So they're already total, we don't talk about them. But suppose they're like that. So we can see they're not total. They're not complete. They're actually partial. So are they similar to each other? Are they congruous? So we say we have a partial right homonymous hemianopia, a congruous partial homonymous hemianopia, because they are similar. But they may be dissimilar like this one. So we'll say we have a left incongruous homonymous hemianopia. This is just descriptive terms. What we're saying is that congruity is only related to a partial homonymous hemianopia. We don't mention it in total, because total is already total. Doesn't need to be further described. So again, any post-chiasmatic, if you find a homonymous hemianopia, say this right side homonymous, it means what? Means that we have a post-chiasmatic lesion on which side? On the left, the contralateral side. If we have it on the left homonymous hemianopia, whether total or partial, then this means that the lesion is post-chiasmatic, but on the right side. So it's either in the right parietal, right visual cortex, right optic radiation, and so forth. So this is another way of explaining it. Say, let's revise together. So if a lesion is at the chiasma, it's a bitemporal hemianopia. It's not total, it's partial, so it's incongruous. So it's a bitemporal, partial, incongruous hemianopia. Number 4 is that where at the optic radiation. So, at the optic tract. Number 4 is at the optic tract. And we see they're not similar. So what do we have? We have a left, partial, incongruous hemianopia. Number 5 looks like a left upper quadrantanopia. It's almost congruous, but you can see here, this is Mayer's loop, which loops in front of the inferior horn, taking it further away from its superior counterparts, and it causes an upper or pie in the sky, as we call it. Now, you'll probably be surprised why I'm putting this one. But I want to go further to explain the visual field defects that will occur if you have a pathology in the occipital cortex. Now, the brain supply actually comes from, of course, the heart, aorta, and the brachiocephalic artery. They both supply the common carotids, which finally enter the brain as the internal carotid artery, giving us the anterior part here. It becomes here the anterior cerebral and middle cerebral artery. Comes out here. And then we have the vertebral arteries, which actually meet at the inferior part of the pons to form the basilar artery here, which again divides to give the posterior cerebral arteries. And this actually confirms the circle of Willich, which we also need to know very well. It's very important. It's a very small circle around the pituitary gland, the ciliary area. And this is the basilar artery that we just mentioned. The 2 vertebral arteries. Here's the internal carotid artery arising from the cavernous sinus and emerging from the cavernous sinus at the roof, and gives the middle cerebral artery and the anterior cerebral artery. So again, why is this important? Because the blood supply from this part that we are very interested in, and not only this, but all the posterior part of the visual pathway are supplied either by the posterior cerebral artery or the branches from the middle cerebral artery. So the middle cerebral artery, you can see, gives the choroidal branch that gives here the optic radiation. And you can see here that the posterior cerebral artery also is important in supplying all the inner parts of the cortical region of the visual cortex and the calcarine sulcus here. In essence, the optic radiation is supplied by the posterior cerebral artery, which comes from the vertebral arteries, and the middle cerebral artery that comes from the carotids, internal carotids. There are parts that it has a double blood supply. Many times, this will help in protecting the central vision. Let's take another look at the occipital area, which has this dual. So the middle cerebral artery is, the posterior cerebral artery is here, the inner aspect. And from the outer aspect, you have the middle cerebral artery. And this is the calcarine sulcus, where the central part of vision is actually represented here at the tip. And as you go inside into the calcarine sulcus, the periphery of the visual field, as the further you go peripheral from the center, the fovea is here, the further you go inside the calcarine sulcus, you'll find that more peripheral areas are represented here. You can see 10, 20, 40, the deeper you go. So as in the end, you will find that there is a very deep part that represents only one side of the visual field, which we call the monocular temporal crescent. It is very deep inside the sulcus. And this would be where it can be affected if it's the most peripheral part. So inside the calcarine sulcus, at the tip, you have the representation of the fovea. And as you go periphery, more periphery, you go deeper into the sulcus until the very end, you reach one-sided representation of each side, right and left, of the monocular part, which is the temporal monocular crescent. So let's take a look again. This means that if at the visual cortex, and even starting from the optic radiation, you can get what is called as macular sparing. So this is a homonymous hemianopia, left homonymous, which means what? Means the right-sided post-chiasmatic visual pathway affection, pathology. But if you have macular sparing, then this would mean that this part has been supplied because it's either the middle cerebral artery or the posterior cerebral artery. So one of them supplied the macula and actually saves it from this infarction. However, in some people who are not so lucky, they may get an artery that only supplies the posterior pole, and this becomes affected, giving only a bilateral central scotoma and affecting the central vision only. So it can be a blessing, or it can be a problem. So this is how we apply anatomy to the neuro-ophthalmology. Now we remember that we said the most peripheral part, the monocular temporal crescent, is actually represented deep inside the calcarine sulcus. So if we have here on the right side, we can see there's a lesion here. Now this is the calcarine sulcus here, and we can see that deep inside here, this is where the lesion is. So which part it will affect? It won't affect the fovea, definitely. And we have 10, 20, 40. As we go to the peripheral, we'll affect the most peripheral area. This part. And you'll probably have what we call a temporal, monocular temporal crescent. Now this can be very far in the periphery, which you won't reach by 30 degrees testing, as we were going to see in the visual field. It can be only found by the kinetic because it allows you to go further outside, like the GOLDMANN kinetic perimetry. But once you document this goes with the infarction that we saw. So this is another application of anatomy to visual field and neuro-ophthalmology. You can see here, this is the monocular temporal crescent here. And you can see here another representation of how, if this side is affected, now this is the right side, it'll give a left hemianopia, macular sparing, or if it's on the left side, it will be a right hemianopia with macular sparing. However, it's if another part, macula, if it's here, the macula may not be spared. Okay, so now the last part, we talked about the anatomy of the visual pathway and how this would reflect on different types of visual fields. We talked about in the optic radiation, where if it's in the parietal lobe, it will affect the upper fibers, so it will give a lower quadrant, pie on the floor. If it's in the lower fibers, give pie in the sky. And how post-chiasmatic will give you hemianopia, homonymous hemianopia, either total or partial, congruous or not congruous. If you have a left hemianopia, then this means a post-chiasmatic lesion on the right side. And we talked that monocular lesions will most probably be optic nerve, but we showed an example where we actually showed two examples. First example is when the lesion is affecting the lateral side of the optic chiasma, it will only press on the temporal fibers from the eye on that side. Say if it's on the right side of the chiasma, affect the temporal fibers from the right eye, causing a left uniocular, left homonymous hemianopia, only of the right eye, while the left is free, the visual field is full. The other example is, we just saw, is monocular, even though it's in the visual cortex, but because it is so deep in the sulcus, there the representation is only for one part of the field, which is only represented for each side, which is the temporal crest. We're moving into, I'm going to talk now about, just take a deep breath first, because I know that the last part was a little tough. Now, this is a short history of how visual field progresses. Visual fields were known since the 2nd century, but of course in the 16th, something called CAMPIMETRY, which we're going to see a picture of, has been introduced. And if you look at the tree on the right side, you'll find minor kinetic perimetry was before the 1950s. And then static profile perimetry, automated static perimetry was before in the 70s. We'll talk about that. And then we'll touch on the frequency doubling technique and the shortwave automated perimetry. As regards how they function, what's the idea? What's the core of it? How do they function? On what basis? So let's start with Jerem's screen, which is a tangent screen. Now, CAMPIMETRY is, when you say CAMPIMETRY, you mean you're examining the visual field on a flat screen like this. It actually means, campi in Latin means the field. So it's as if you're saying I'm examining the visual field. But it's on a flat surface. The term is used for a flat surface. And this, I had the good fortune to see it. It's very velvety black. And you have many targets also. And it's useful for the sense of 20 degrees. I don't think you're going to find this anywhere else. It's something archaic now. But we have here the Goldmann kinetic perimeter, which was Hans Goldmann work in 1945. And up till now, by the way, at Wills Eye Hospital, they have 2 of these machines, and each patient gets a kinetic perimeter done as well as a static on the automated perimeter, because the information given by this is different from the other. So actually, the Goldmann kinetic perimeter was the basis for a few things used in the automated one that we use today. What do they test? Now, in the kinetic, now this is the normal hill of vision. We find that the sensitivity is greatest, peaks at the fovea here, and then slopes down, but actually dramatically at the 20 degrees, it flattens out and begins to rise at the 20 degrees. So here the sensitivity is much less than at these areas. What he does is that he moves the target from an unseen area like this until it is seen. So let's start from this side, for instance. He moves the target, okay, the patient can see. The kinetic perimeter, it's of a certain side, and he reaches, okay, the patient sees it, so he marks it here. And then he moves it on another area, and he marks here. Then he moves it like this, and he marks here. So this forms a line, as we will see, and then he gets a smaller target that needs a higher sensitivity and moves it along until the patient says, yes, I see, okay, and then moves it along this meridian and so forth. According to the sensitivity, the patient will see. So what does this, I don't want you to know anything about from here except one thing, that the sizes that used for the targets actually describe the areas in millimeters square. The one we use in the automated perimetry comes from here, size number 3, and this is equivalent to 4 millimeters square. And we also use size number 5, which is 64 millimeters square, which is about multiplied by 8. More than that, actually. Multiplied by what? Okay, we'll keep that to later anyway. So anyway, the size we use in the automated perimeter is 3, and the other size we use is 5. It comes from the Goldmann targets. And they also had numbers with intensities, so the Arabic numbers 1, 2, 3, 4 indicates a certain brightness, and then E, A, E, or the alphabets indicate a more fine adjustment for the illumination. So the smallest and dimmest targets would be 0, 1A. The largest would be V. This is the size. 4 size, and then the illumination 4, and E would be, this is the highest intensity, 4E. The lowest would be 1A. Now, again, we're talking about kinetic perimetry here. So a test object is moved from a non-seeing area into a seeing area until the patient sees it, radially from the point of fixation, going on until he sees it, and it is marked by the technician or the doctor who is doing the visual field. And each line is, we draw here from pointing from one point to the other to this, is called an isopter. And all these have equal sensitivities. This is where the same target was first seen. So we begin from the periphery and we mark the target and then choose a smaller target, which will not be seen here. It will be seen only in a more sensitive area as we go through inside until we finish. And we plot we make the isopter plot. And in the end, this is how we have the kinetic chart, perimetry chart. So we'll find here is the largest target, and we find here that we have a very small target, which is 1, Roman numeral, and then 1E, which is very small illumination. And because this is a very sensitive area compared to the V4E, which is much less sensitive. So this is how they draw the isopters, and they print out the chart. From the Goldmann, excuse me? Okay. From the Goldmann perimetry, we move to the kinetic, we move to the static. Now the static depends on what? Static is just measuring the threshold. The threshold, we understand it, is the when we are able to appreciate a point of light with a certain background, over a certain background. So this is the threshold. When we just are able to recognize this point of light. But actually it has a definition, because at that point, you can recognize something here, but this will be super threshold. So what is the threshold? Threshold means that it's the amount of illumination, intensity of light, that you would be able to see 50% of the time. So if this is the 50%. If the intensity is lower, then you'll see it 25% of the time. If the intensity is higher, this is the intensity. If it's higher, then you'll be able to see it more than the 50% here. Okay, so this is the intensity. Sorry, this is the intensity here. So here it's brighter. So if it's brighter than the threshold, then it's called suprathreshold. If it's lower than what you're able to see, usually 50% of the time, it's infrathreshold. So that's what it does. Now, in the automated perimetry, static one, the threshold, as we said, results in a 50% probability of perception. Suprathreshold is not 100% actually. It is more than 50%. So what does he do? How does this be achieved? Remember that each point of these is tested for its threshold and mapped out on this plot. We'll be getting to this in a minute. How is the threshold achieved for each point by the automated telemetry? And there are many programs, and so let's say the Humphrey. Let's take the Humphrey as an example. So let's take the 30-2. So when we say 30, we mean that it goes out 30 degrees. So here is 10, here is 20, here is 30. So you go out to the 30 degrees. Okay, there's 40, there's 50, there's 60, as we know. We remember from when we said that temporal reaches up to 100. And the nasal may reach to 60 degrees. Okay, so you still have a range, but we only restrict ourselves to this 30 degrees. So what is -2? Now, in the beginning of Humphrey, they used to test along these lines, here, 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 here. There was no -2. And they found that testing here doesn't actually provide any additional information. It's useless. And what was more useful was that they would test here and test here. Test here in the upper half and test in the lower half. Test in the lower half and test in the upper half and compare these 2 points together. So this is the -2. -2 means comparing two similar points or two similar areas. Actually, there are areas and that are similar in the superior to their counterparts in the inferior half of the field. So in the center of 30 degrees, many points are tested, actually 76 points. If you do a 24-2, which actually has a different shape, it goes up to the 30 goes up to in the nasal field. This is the nasal because the blind spot is always in the temporal field. And it's not circular. It takes this shape like this. It goes out to 30, but all the other is up to only 24 here. So it has less points to examine, it makes it faster. Now, how does the field begin? You put the patient or you're doing the visual field for yourself. What first does the machine do? The first thing is it maps out the blind spot. This is the blind spot. The first thing the machine does is that it searches for the blind spot. And that's why it's very important that you have to indicate which eye. So the blind spot is in the temporal field. So this is the left eye because it's in the left side. The blind spot is here. If you put that you are doing the right eye, the blind spot mapping will try it here and will tell you it can't find the blind spot. And if you go on to do it, in the end, the visual field pattern will come out with 2 blind spots, one here and one here. Mapping out that this should be the blind spot, and this, but this is where you're seeing it. Anyway, so first thing it does is maps the blind spot, and it maps it according to what you write. Is it right or left? And then it begins to determine retinal threshold. We talked about what threshold means, and now we're going to talk about how it does it. First, where it does it. So it starts at 4 points. The first point is like you see the star here, 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 and here, which are 10 degrees away from fixation. And this is the first point that it maps out. And from the conclusion, from the numbers, it extrapolates how to continue to measure all the other 72 points that are left in the visual field. And that's why sometimes you get a certain type of visual field that we'll talk about later. Now let's talk about how it estimates the threshold. At first, to any point of these, it presents a threshold, a high threshold, okay? And then, okay, you saw it, and then it decreases by 4 decibels, goes down. Okay, you're seeing this, okay, it goes down here, okay? And then it begins to increase it by 2 decibel points. This is called bracketing technique. So the first thing, it gives a very high threshold, that you're a very high intensity of light that's supposedly above your threshold. Of course, if you don't see it, then it's going to be give you a higher one. And then it begins reducing it by 4 decibels. What are decibels? Decibels are a unit which indicates your appreciation for perception of brightness. But they are actually intensity, the light intensity is increased or decreased. So it begins by a high intensity light and then decreases it by this amount, the decibels, until you can't see it. So then it increases it by 2 decibel increments until you see it. Once you see it again, then this is recorded as being the threshold. Now, the 4 initial thresholds are then used as starting points, and all the other points are then examined in the same manner, going above and going below, bracketing 4 decibel changes and 2 decibel changes. If they find that the value varies from what is expected, then by more than 4 decibels, it remeasures automatically. This actually, to consider 1 point abnormal, it has to be compared to its to the statistics that is put in the program StatPack, which compares any person to his age bracket. Now, remember what we talked about when we said that the first points that are measured are the central, in each quadrant, 10 degrees from fixation. So if somebody is getting weary and just paid attention in the few minutes at the beginning of the test, you'll find that he probably responded only to these 4 points and then just neglected all the others. And this is what we call a clover leaf pattern. This is the clover leaf. This is how it looks like. And this is another shape of it. So now you understand why, because that's how the machine begins to test for the field. But however, some people actually, when they still starting to test, it's the first time, they don't understand the test until after this has passed. So they begin to respond to the stimulus after not pressing for these 4 points, and you get a black clover pattern appearance. In either way, now you understand why this can happen, which is based on how the machine works, how it is programmed. So we have the white clover leaf pattern here, and we have the black one. The black one means that initially the patient wasn't paying attention, instead of getting weary or not paying attention later. There are several papers actually that show the differences between the kinetic and the static. The good thing about the kinetic is it's fast. It can go out to the wider range, and it can show other things that there are many points, but what I'd like to bring your attention to is what's the famous spiral defect, that you can get it on an automated static perimeter. And this shows in case that this patient is what we call a functional visual field loss, which is either hysterical or malingrar. Now, moving from, let's take 1 minute. Because I know that this is a lot of anatomy, and I'm going to add still further to you. So this is the macula, and this is how it's projected to the visual field. So the optic disc is projected to the blind spot here. Now, the macula, which is supposed to be 5 millimeters, is about 18 degrees. So this is the macula. So it's 18 degrees. So when you measure 30-2, you're actually measuring also this part of the field, which is outside the macula, up till here. But I want you to notice that the fovea is 7 degrees, 1/2 millimeter in diameter, which is equal almost to the disc, to the blind spot. It's 7 degrees. I want you to remember that. And the foveola, which is the center, now this is important. It's 1.5 degrees. Because from here, we're going to talk about another aspect of how the algorithm of the automated perimeter. Now remember, the foveola is 1.5 degrees. From here to here, this is 1.5. So now this is the distribution of the points tested in a 30-2 visual field, perimetry. You will notice that the first point tested, the closest near to fixation, are actually further away. And then each point is tested at a certain space. So the machine does, what does it do? It tests here and tests here and tests here. And then what about the points in between? It just extrapolates from here to here. The intensity, the sensitivity here is so, the sensitivity here is so. So it assumes that it is a gradual line, a graphic line to be stretched from intensities of these points to each other. But if we look at the numbers, so the spacings, the first spacing is 2 degrees, and then it becomes 6 degrees. So let me give you a case of a young lady, 19 years old. She was in the tourist faculty, very pleasant young girl, young lady, and she came complaining of decreased vision. Now her refraction was perfect. She didn't have any problem with her refraction. She never wore glasses. The OCT, fluorescein, and geography, she came with a bunch of tests done. All were excellent. And she even had an ERG and the VEP that were normal. Now, the visual field was full, but she couldn't see. She said her vision had dropped, and actually she was I think down to 660 or 636. So that's quite a low vision. And we could find no pathology. Why? If you have a lesion here in the foveola, it will be missed because we said that this is 1.5 and the first point tested is 2 degrees away. So a lesion here at fixation will be missed. You'll get a wonderful visual field and you're going to miss this. She was diagnosed by a multifocal ERG to have a problem right here in the foveola, unfortunately. And I really hope that she would be hysterical or something, but the multifocal ERG showed that point here. And from this, I learned the importance of understanding the limitations of our visual field. So if you see a visual field that's full and wonderful, and the patient is still complaining that he's not seeing well, remember, the visual field doesn't test this area, the center of the foveola, which is 1.5 degrees, because it actually begins its test at 2 degrees. So they thought, okay, we know that we have a central area that's not being tested properly. So what did they do? They made a 10-2. Now the 10-2 has points. Now this is up to 10 degrees, by the way. It's not 30, this is 10. And they made the tests closer to each other. So this is where we're testing, this area. And the parameters were that the first degree is about 1.5 from fixation. And then the spacing are closer to each other, about 4 degrees from each other, not 6 degrees. So they have more test points in a small area, much more than in the 30 or 24-2. but still, the first one is at 1.5, still missing all this area. I hope I made this point clear for you. Okay. I'm sorry, there's a lot of anatomy here, but if anybody wants to understand visual field, you really need to know your anatomy. So, we are looking at a topographical distribution of the retinal nerve fiber layer of the center part of the retina, the macula, and an area outside it. So what do we see? We notice here first that we have a papillomacular bundle on the temporal aspect of the optic disc. So this goes straight. Any point after that on the temporal part of the retina will have to go around this maculopapular bundle. We'll have to curve around it to reach its point in the side of the optic disc. Contrary to that, you'll find that the nasal fibers actually just converge onto the disc. They don't have to swerve around, angle around anything. So now the nasal fibers always see the temporal field, and the temporal fibers will see the nasal field. Remember that when we do a visual field, it's not centralized here, it's centralized here. That is why the optic disc, which is nasal, gives a blind spot that is temporal to fixation, because this is where we measure from. This is our fixation center. Okay, so let's see. If we have a lesion that affects this part, takes this for instance here. So what will it cause? Now the optic disc here is the blind spot, and it will cause a lower arcuate defect. Why? Because it has to go around the maculopapular bundle, which is here. This is the maculopapular bundle. That's why you have an arcuate defect. Of course, it doesn't have to affect the whole bundle. Actually, it can affect only a small part that, say, represents this area here. It can affect, of course, more than that, and can take the maculopapular bundle, causing an altitudinal field effect. But if it only takes this part, it will cause, say here, it will cause what? It will cause a defect on the nasal field, which we call a nasal step. So this is a nerve bundle, right? So an arcuate defect is a nerve bundle defect. A nasal step is also part of the nerve bundle defect. Okay, this is concerning the temporal fibers. They will cause nerve bundle defects of this sort. But what about if we have a defect from the nasal fibers, which will affect the temporal field? It will be wedge-shaped. And where is it going to end? This is the disc, so it will end in the blind spot. Correct? So these are nerve bundle defects, either a nerve bundle that is the nasal fibers, which will cause a temporal wedge, or it from the temporal fibers, which will cause either an arcuate or a nasal step. Now, there are still a few points we have to talk about, but before I continue, look at this one. Now, this is a temporal wedge. It's ending here at the blind spot. Let us remember this. Now, this is the pie in the sky, or what we call quadrantanopia, an upper left quadrantanopia. It has no relation with the blind spot. Even here, it actually ends at fixation because it's not related to the anterior part of the visual pathway. This is related to the post-chiasmatic pathway. Now, if we're going to talk the maculopapular bundle, so this is considered with the central vision, correct? Let's take a look. So it either can cause a central field defect, so this is maculopapular, or it can be extend to the blind spot, as we see here. This is the blind spot, and the fiber extends, so the whole thing can extend to the blind spot, and so it's called a central cecal scotoma. Or it may not be central, maybe just paracentral. Paracentral is a central scotoma within the central 10 degrees. So that's a maculopapular bundle, other than the nerve bundle that we talked about. Now, let's talk about the nerve bundle. We talked about if we have an arcuate defect. Okay, suppose you have a defect, several defects. I mean, you don't have it arcuate. So this is what we call defects in the germ areas or germ scotoma. So this is within 25 degrees of fixation, which is this blue line. Any defect it's also a bundle defect. It may not be taking this nice arcuate, not full arcuate shape, but it can be patchy. So these are also nerve bundle defects, and we call them germ area visual field defects, or just germ defects, germ scotoma, because they're in this area. Now, let's talk about the blind spot. The blind spot actually can become enlarged, as we see in cases of papilledema and optic nerve hydrusum. Or another scotoma can sort of arise from it. So this is also a nerve bundle defect, because instead of arising at the end causing a nasal step, it's arising close to the blind spot. It represents this area close to the optic disc. And this is called this is called a sedal scotoma, because it looks like some types of plant seeds, which have this feather and they fly with the wind. So this is called a sedal scotoma. So we have maculopapular bundle scotomas. We have nerve bundle scotomas, either related temporal wedge or nasal step or arcuate or germ's area. Central, we can have a paracentral scotoma. We have a kind of central cecal. We can have a central scotoma, or we have enlargement of the blind spot, or we can have a sedal scotoma. So these are the type of visual field defects that come from the anterior visual pathway. By the way, in cases of optic neuritis, every and each type of visual field can be represented and can occur. And this is from the optic neuritis treatment trial. All of these types of defects can happen. So these are the anterior part. So anterior part of the optic nerve. What we talked about previously in the chiasma, this is inside the brain. And they usually, at that area, if we remember, they respect the vertical line. Here, you will notice that there is respect for the horizontal line, except maybe for the temporal wedge, which crosses it can cross to the blind spot. I want just to remind you that if you're looking with an indirect ophthalmoscope, already the image of the retina is upside down. So if you have a lesion along here, it will actually will go along with the same visual field defect, the arcuate. So it's superior here, you have, it appears upwards, which is really down. So you have an upward field effect. But if you look with a direct ophthalmoscope, then this will be, of course, different. So moving from anatomy, more to physiology. This is to explain a certain type, an important type of visual field. We've talked about machines, we've talked about types of visual fields and how they are explained anatomically. And now we're going to proceed to a certain type of perimetry. Now, the blue cones were actually discovered anatomically quite recently in the 1987 in this paper. And they are actually absent in the central part. So actually we have a blue scotoma in the central fovea, which is, as we said, is the foveola, is 0.35, is part of it actually, in the umbo, which is the center part of the foveola. You don't have blue cones here. Now, why are they important? So we have every types of photoreceptors that we know, and the rods, we have the cones with the three colors, long wavelength, middle wavelength, short wavelength cones. But they submit their information through certain pathways, and they are controlled by the ganglion cells. And the ganglion cells, we have the parvocellular ganglion pathway, which mediated by the parvocellular ganglion cells, begin with it. And these carry the green and the red colors, along with other things. Proper vision, sharpness of vision, and so forth. But you also have especially in the periphery, the magnocellular ganglion cells, which are large, and these carry mostly the movement. And they take from many rods and cones. So they control areas in the peripheral field, the M cells. And then you have the blue-yellow pathway, and this is called the coniocellular pathway. So the parvocellular pathway transfers color information, high contrast information. The coniocellular transfers blue and yellow. The point is that the conioganglion cells represent only 5% of the ganglion cells. So the blue cones represent about 7.7% of all the cones in the retina, but the conioganglion cells actually represent even less, only 5% of the ganglion cells. So the point is that if we can test only these, we can detect defects earlier than if we're testing every part of the retina and all the ganglion systems. So this shows just that we have the coniocellular pathway and you have the magnocellular pathway. It goes to certain parts of the lateral, the magnocellular goes to certain parts of the lateral body and actually has a certain area in the visual cortex, this layer 4CA alpha. The coniocellular, which is present between several layers of the lateral body, actually ends in this layer. It's a very separate layer here. It's layer 1 in the visual cortex. So you can see that there's an important separation here. So what they did was they said, okay, let's do a shortwave automated perimetry. If we have such a small number of cones, then maybe we can detect lesions earlier. And this is called the SWAP, shortwave automated perimetry. It gives a beautiful bright yellow light. If you try it if you have a machine, you can switch it on the SWAP. You'll find that it takes a few minutes, and then suddenly, the inner part of the machine lights up with this very bright yellow. So why did this choose the yellow? Because actually the yellow will cause adaptation of the reds and cone systems, the parvocellular, leaving the blue and yellow system to act. So you can see here without the sensitivity without the yellow light, and the sensitivity of the blue-yellow system or the coniocellular system becomes more prominent when you adapt the eye to the yellow color. And this way it isolates the shortwave system. And papers have shown that many papers shown that glaucoma visual field deficits was actually identified earlier than the standard white on white. White on white means that this inner part is only whitely illuminated in the normal white color. And they use it to diagnose early glaucoma suspects that appeared normal with the ordinary visual field results. So this is one application of knowing the physiology. However, if you have nuclear sclerosis and then the yellow will be absorbed, so it's not good for the old age. It's good for the young, not good for the patient with cataract, and it's quite short actually. So let's talk about the magnociliary pathway. And we can see here that we talked that it's motion and low, and actually 10% of the fibers. So the same concept, they thought, okay, let's create a machine for that. And from here, got the frequency doubling perimetry. You can see the machine here, very elegant, very small. Its advantage is you don't need correction for it. No correction is needed. And what you see is this flickering. It appears a flickering of light. And once you detect it, you press the button. And this is how it measures the visual field. And it's very easy for the one who's being tested to use. It's not present in many places, actually. But just to get an idea of how they applied the physiology to create methods for testing visual fields. Probably when I first started, when I was a junior doctor, I took a great interest, and I used to sit by the patients on the visual field, the first Humphrey, which didn't have the -2, and try to learn a lot about it. And I found that it's mostly about statistics. So when I began to learn, I found that I understood nothing because I didn't know anything about statistics. I had to learn statistics to understand the book. But now, how are you going to see the patient? What should you do? Now, these are a few tips for those who are doing visual field or who want to do it. Many of the experts here we have already are doing it properly, just to remind them a few things and for the novice to learn. First thing is you need to explain to the patient what he's going to do. You really need to walk him through what's to be expected, what he should look, what should he see. So first thing you have to explain, of course, that he needs to fixate on the targets inside the dome of the visual field machine, and to tell him that some spots will be weaker. He shouldn't ignore them. He shouldn't just press for the strong ones. And if he's tired, he should indicate that he's tired or keep pressing the button. If he keeps pressing the button, the machine will stop until he removes his finger, and then it will resume the test. Now think about it. The test usually takes an average of 10, 11 minutes, sometimes even more. None of us can keep his eyes or her eyes open for even a minute. We need to blink many times in a minute. So you have to allow the patient to blink. You can't tell him, don't blink. I had many patients who come to me complaining severely of this test and how much they hate it because they didn't understand that they can blink. So they say their eyes keep watering, they get severe pricking sensation, they can't focus, and so forth. So what you say, you allow the patient to blink, but suggest that he should blink when he's pressing the button. So he saw a target, and he wants to inform the machine that he saw it by pushing the button. While he's pushing the button, that's the time he should blink. He won't miss any testing at that time. Of course, when you want to see the patient, he has to be comfortable. He has to see that his chin is fine, his body is erect, not sideways, and this sort of thing. Now, what about refraction? So refraction is very important for the center of 30 degrees. if you're going to examine beyond the 30 degrees, that's not important to put a proper refraction. You have to put the refraction, and the machine calculates the add that you need to put for the machine. Because if you don't, there'll be a refractive scotoma. When you put the lens, it has to be as close as possible to the eye, but just beyond the lashes. He shouldn't be irritated by it. So, would you put a cylinder if he has astigmatism? Yes. If it's above 1.25 diopters, yes, please correct. Put a cylinder lens. You don't need below that. Because each diopter will actually cause, each diopter difference, defocus, will cause a drop of sensitivity by more than 1 decibel in the central 6 degrees. So you don't want, you want your testing to be perfect. So what about patients with poor visual acuity? Should we use large size, or should we continue with number 3, the 4 square millimeter? Actually, if it's a glaucoma case that, you know, he's a glaucoma case and the visual field has dropped, it means that the central vision has dropped. It means that his visual field will be bad. Use the size 5. However, if you know that there's a macular pathology that's causing this low vision, then you can use the normal size 3 for this case. Now, we used to measure the pupils in the past, just to understand that if the pupil is very narrow, something called diffraction will occur, which will make the image distorted. If larger than 6 millimeters, spherical and chromatic aberration will occur. This we learn from the optics, of course. So it will also distort the image. So this is just for your knowledge, because right now you can't change anything. A myotic patient will have lower light entering his eye, so the sensitivity will appear to be dropped. Also, over and above the diffraction from the pupil being so small, that as occurs in senile patients. Now, just I touched on something that's actually written in many books. Now, I found this, many books talk about Wilbran's knee, junctional scotoma, where you have an eye which has a central scotoma, and the other eye, you find that there's a temporal defect. And the explanation is that the lesion compressed on one optic nerve, and that the Wilbran's knee going up into the other side of the optic nerve is being compressed, and hence this would be the nasal fibers cause the temporal field of the other eye. So it's compressing here what is assumed to be Wilbran's knee, causing this defect, while compressing this optic nerve causing the central defect. Well, von Wilbrand actually did his work on enucleated patients. So they have one eye. And it turned out that Wilbran's knee actually doesn't exist. It's an artifact in preparation of the slides. And that the scotoma, the junctional scotoma, actually, there's no crossing up into the optic nerve. It's simply that the lesion compresses the central fibers here and the crossing fibers from the nasal side, from the nasal retina crossing across here, and so it's being compressed. And that's the explanation. So you can have a junctional scotoma, what we know now as junctional scotoma, but understand that the lesion isn't at the junction. There's no Wilbran's knee. Okay. So I thought we'd put here some slides of visual field effects to look at it together. So here you have the concentric loss, like the first thing we saw, how the visual field can constrict. So it's concentric loss, or you can have it like this, can be annular. But this usually is not of neurological case, usually like case like retinitis pigmentosa. You can have a generalized reduced field, which actually can occur if it's meiotic or cataract, or in glaucoma cases also. You can have a central scotoma. We talked about that, a paracentral scotoma. You can have scotomas within the gerimus area. Or you can have what's this? This is a central cecal scotoma, taking the blind spot and the central area. You can have, now this is coming a sector shape. It should not be on this side. It should be more on that side. So this could be. So this is a temporal. If it's a temporal wedge, it should be here like this one. So this is a temporal wedge, but this is not. This would be a sort of quadrantanopium, a sector shaped. It's reaching the fixation. Blind spot can be enlarged, can be a cecal scotoma. Sometimes a rotation can occur, and you find the blind spot in another area if the eye rotated. Okay, so we have this, the arcuate scotoma that we know. Then it's a nerve bundle scotoma. It can be a hemialtitudinal. Now this is another temporal wedge. Now this is centrocecal scotoma. So this is respecting the horizontal. This is respecting the horizontal. Not respecting the horizontal. So here, this is a nerve bundle defect. And this is also a nerve bundle defect. This is also, why is this a nerve bundle defect? Because it ends in the blind spot. This ends at the fixation. So most probably it's related to post-chiasmatic lesion. Like this is a quadrantanopia. This is a hemianopia. This is not a nerve bundle defect. It's respecting the vertical, so it's post-chiasmatic or chiasmatic like we saw. It can be compressing the side of the chiasm only, not affecting the crossing of the fibers. Or it can be even central and respecting the vertical meridian. So in the nerve bundle defects, you notice here, these are the temporal fibers causing this defect. These are the nasal fibers causing the wedge defect, temporal wedge. These are the maculopapular bundle fibers, centrocecal scotoma, and the altitudinal defect. Altitudinal defect, I'd like to say, in neuro-ophthalmology, it can occur, of course, in retinal cases, in no branch hemialtitudinal hemi-branch vein occlusion, or hemi-artery superior or inferior artery occlusion, or it can occur in ischemic optic neuropathy. You can get this a lot in the ischemic optic neuropathy cases. Now, this is a slide from the course that I started, which is the basics ophthalmology skill transfer course. And a very simple way of testing the visual field is by confrontation, simply by confrontation. So face to face, you look at the nose and you make the patient fixate like you do in the visual field. And then you start testing. Very easy is this type of testing. When you're asking him if he can see your face, all of your face, or half of your face can only be seen. So this can show you hemianopias of different types, can show you altitudinal defects. This is the finger counting, which will show if you say how many here, it will also show you these types of quadrantanopias, hemianopias, altitudinal defects, and so forth. So visual field confrontation is also a very quick and easy way to examine your patient. Of course, that's much more to it than this, but this is to give you an idea about it. So, if we don't mention the Amsler, that would be a great mistake. So Amsterdam, since 1945, measures about the central 10 degrees, and it has many advantages. To use it, you have to make the patient use his reading correction about his reading distance, and to fixate on this center. That's how you ask him. Tell him, fixate here. And then you ask him to look first. Ask him to fixate. Okay, you're fixating. Okay. Now, where are you looking here? Can you see the 4 quadrants? He would say yes or no. If he doesn't see them, he said, please mark where you're not seeing. If he sees them, you go on. Are there any missing patches here? And he's also delineated. The nice thing about it, he can draw exactly where he's not seeing, while always looking at the fixation. The extra thing is that we can ask him if any of the lines here are distorted, because this is an important indication of macular edema or CNV. So this is how you can use it. So it's within the 10 degrees, and you can see how it very effectively can detect very small scotomas in such a small area. If you compare them with the other one, which was 6 degrees apart, 6 degrees apart means that actually you're only taking 1 in the 30-2, 1 point being tested here, 1 point being tested here, and so forth. But here you can see how many multiple points are being tested with this simple test that you can do in the clinic. So before we continue, is anybody unhappy? Oh, I'm hearing nothing actually. So I hope you're all happy. But anyway, if you have any questions, please put them write them down, and we'll come to them later. So great. We're going to continue. Good for you. And I'm going to talk about the charts. Now, this is a little tough, but this is the end of the lecture now. We're almost finished. So there's something called apostle. It's simply a unit of illumination. Okay? It's an absolute value. It's something that you can measure. However, luminance is the appreciation of brightness. So it's something relative. And we measure it by something called a decibel. So how is the decibel established? It really depends on the type of machine. So each manufacturer actually has a different decibel from the other. It's not an absolute value. So for instance, the Humphrey can give a 10,000 intensity apostolbs illumination power. It's very strong light, while the octopus gives 1,000. Both of them establish that the decibel, the 0 decibel to their perimeter's brightest light. What does this mean? It means that for Humphrey, the 0 is when you can't see the 10,000 intensity. And for the octopus, the 0 is when you can't see the 1,000 decibel, because this is the maximum light they have. So it simply doesn't mean that you're blind. It simply means that the 0 point is you can't see that intensity of light at that point for that machine, which differs from one machine to the other. That's why you can't compare visual fields from different machines. Maybe they'll show you a pattern, but they can't be compared, especially in case of glaucoma. Now, for instance, in Humphrey, the 0 means that you can't see the 10,000 apostolbs of units of illumination. The dimmest is 50, so it dims to 50. So between 0 and 50, this 10,000 decibels is divided. So an increase of 1 decibel equals mean sensitivity equals a 20% decrease. of the apostolbs. So the more decibels you have, the more sensitive you are, because you can see a dimmer light. The less decibels you have means that your sensitivity is not that great and you need higher luminance, more powerful light. So the maximum intensity for Humphrey is 10,000 apostolbs, sorry. And the 0 decibel corresponds to the maximum intensity of each. 1 decibel is 10,000, means it cannot be seen at that intensity. Now, the importance of looking at a graph is actually, I need to explain a few points regarding the machine. Of course, when you first look at the graph, you need to look at the whole thing. Now, you have here the data that shows the fixation, the false positives, and these are catch trials. They express the reliability of the test. So they are the reliability indices. So the fixation losses is tested by the machine. How? By always going back to the blind spot. If the patient presses that he saw where the blind spot is, it means that the blind spot has changed. It means he has moved its eyes and the fixation becomes improper. False positive errors means that the patient is just pushing the button at the sound of the machine. I mean, the machine sometimes gives the same sound that it gives if it's going to give a target, a light target test. So it gives the sound, but it doesn't produce the light. If the patient presses, or if he's trigger happy, he'll just push the button without seeing any light. So this is false positive. False negative is that he has seen a point at a low intensity, and then you give at that certain point a higher intensity, and suddenly he's not seeing it. So this is a false negative because he's supposed to see it. So these are the reliability indices. The fixation losses, if they are more than 20%, is considered unreliable. If the false negative and positive errors are more than 33%, also unreliable. What else should we look at? We look at, C indicate that the silence of the stimulus is proper, the one we chose. And very important that we look at the age. Why? Because the database that's all the numbers are compared according to age. So they are stratified decades, say 40 to 49, 50 to 59, 60 to 69, and so forth. So if you don't write the age or put an improper age, he will compare him to in an unjustified way to a person who is either younger or older and give you a false result. So age here is really important, and you must be accurate in feeding the machine with this piece of important information. Now let's take a look at the numerical value. So here this is the numerical printout. It just shows you point by point, every point of it. The decibel value, the sensitivity of each point. So of course, it's supposed to be highly sensitive in the center and least sensitive as you move to the periphery. And compares the if he's a Humphrey, he could not see the 10 apostolbs. There's intensity. 33 means he's more sensitive, and he was able to see a lower intensity of light. The grayscale here approximates things. So it makes the zero more black, the area that is seen more white, and gives you a rough idea of what the visual field pattern looks like. But it isn't what we should really look at. What we should look at is this. Now, the numerical data is being here compared to point. He should have been being much higher than how much he deviated. Wow, he's deviated minus 32. Minus 32 is here is 1. He's fine. He appears to seeing a little better than the average. Here, 0 means he's equal, at this point, he's equal to the age match control, which is present in the database and the machine. So the machine, in order to say if there's a deviation or not, compares each point with the similar age group that the patient is in. And then it plots, it gives a plot here. We'll talk about this plot. It's a probability plot. But it also does something else. Here, what it does, it's called a pattern deviation. What it does is, if you have a uniform depression affecting all points, say by 4 decibels, then it removes the 4 decibels. And in removing that, it makes localized scotoma more apparent. If it's 2 decibels, it removes the 2 decibels. Suppose somebody has a generalized depression because he's myotic, he has cataract, and so forth. So it will remove this depression and make localized scotomas and patterns more obvious. So this is what we call the pattern deviation. When there is no generalized depression to be mentioned, or very small, so for instance, here he considered that maybe at this point it's -28 becomes -30. So the 2 diopters, 2 decibels, -34, -32, and so forth. Anyway, so if it's small, you'll find that the total deviation plot will not be different from the pattern deviation plot. Probability plot. So what do we mean by that? Now, I'd like you to notice here that each point here doesn't mean that the patient is not seeing. See these squares? So this indicates the probability to be less than 0.5%. What does that mean? It means that the probability of this point being normal is 1 in every 200 patients, which is 0.5%. It doesn't have to be abnormal. But that's what it means. It means that the probability of this being normal is 0.5%. If it takes this shape, then it means it will be just less than 5%. And so forth. So these are probability plots, same for the pattern deviation as well as the total deviation, just to show the possibility of abnormality versus abnormality. So this 199 of the 200 patients tested will be abnormal. Only 1 will have the possibility of being. So a visual field test, the black here doesn't mean that the patient is blind in this part. It means that the sensitivity is less when compared to his age match controls. Then we have something called the global indices, which shows glaucoma hemifield test. Now, this compares the upper field with the lower fields. So it compares the upper part with the lower part. If it finds that significant difference, then it says outside normal limits, maybe borderline, maybe within normal. Visual field index is a very general term. It shows how far it is from the normal visual field. The mean deviation, actually, it shows, it calculates each point, sums them up together, how many decibels, divides them by the number of points tested, and gives us a mean value for the deviation in all points together, and plots them. So its probability that this is normal is less than 0.5%, same as with the pattern standard deviation. So these are the global indices. In the end, we have something called the tracking system. Many machines have it now. Upward deflection means that the patient moved his eyes. Downward deflection means that the patient closed his eyes. So I've reached the end of this lecture, and I'm ready for any questions. Okay. Okay, so I'll go on to, okay, anybody please write your question. If when I finish, we can talk actually. So how do you read the Goldman report? Actually, the Goldman report will show the isopters being collapsed at one end or absent. So it will show where the defect, where it should be curved outwards, say it's concave inwards. That's how it shows according to where the defect is. The 10-2, we talked about it. The 10-2 actually tests only the central 10 degrees. It has more points to be tested. And it's the first point that's tested is 1.5 degrees away from the center. And each further point is 4 degrees from each other. The whole point that I mentioned, the Wilbrand knee, is to say that it doesn't exist. So a junctional scotoma doesn't mean that the pressure is at that certain point. It simply means that the scotoma causes a central, the lesion is causing a central scotoma in one eye, and then causing a temporal visual field defect for the other eye. Wilbrand explained that based on the fact found, it wasn't a true anatomical finding, because he was examining in nucleated eyes. So there was atrophy and degeneration. So there is no anatomical Wilbrand's knee. The nasal fibers from the optic nerve of one eye simply continue through the chiasma to the right optic tract, say from the left optic nerve through the chiasma to the right optic tract. They do not swerve upwards into the optic nerve. This turned out to be an artifact and a fallacy. So we can't say Wilbrand junction scotoma because there's no Wilbrand's knee here. That's a nice question. What's the difference between arcuate and germ scotoma? So, germ area is simply describing a scotoma within the central 25 degrees. Simply. Arcuate is describing the shape. Now, a nerve bundle doesn't have to be a nerve bundle area, the arcuate area, curving around the maculopapular bundle to reach the disc. Not necessarily have to have all its points damaged. It can have patches only, which will lie in the germ's area. So if the scotomata lie in the germ's area and not taking an arcuate shape, we call them germ scotomas because they lie in this area. They're not giving us a shape. But if they're giving us a shape, say altitudinal, or they're giving us an arcuate defect, we call them arcuate. It's a descriptive term. No, who said that the pattern standard deviation is positive? If it can be from -6 to -12, it's like the mean deviation.